Thank you so much, Tony, for that introduction. I'd like to begin with a story of a young man named David. And you're going to hear it in his own words, and I'll tell you a little bit more about him afterwards. But as you listen, I want you to capture whether there are particular phrases or words that he uses that stick with you. Okay?
None of the people I knew in the sandbox is alive today. I was shooting basketball with friends at the playground the first time I saw someone get shot. It was random. I didn't think something like that would happen to me or my family. I have seen a lot. Now I don't sleep at nights. Last year my cousin was killed at home in his bed. While everyone is sleeping, I stay awake. I go to sleep in the morning when people are up and moving around. When I do sleep, I have nightmares. Sometimes I wake up crying, feeling lonely, wanting revenge. I wake up paranoid. But there was something that really hurt me, even more than when I got shot 3 times. I was sitting in the street with my brother's head in my lap. Dude stood over him holding a gun before running away. Dude just left. There was nothing I could do. My brother wanted me to hold him. I was crying, panicking. He said, "I'm going to be all right." Little did he know, he wasn't. After that, I knew I would get shot. I started imagining how it would be and how I would hold my body so that they wouldn't shoot me in my heart or my head. When walking in the streets, I would think about how to turn my body so that the bullet would hit my shoulders and not my heart, or how I would use my hands and arms to shield my head. I'm always looking back over my shoulder at my own shadow, hoping that one day I would stop focusing on my past, but looking ahead to my future.
So David is a participant. Thank you. The stories in the words of young people are often particularly powerful. David is a participant in the program called Healing Hurt People, a hospital-based intervention for victims of violence in Philadelphia that seeks to use a variety of strategies to help them heal not only from the physical but also the psychological trauma which you've heard about. Now, just for a moment, what things might have stuck out in his story. He says, "None of the people I knew in the sandbox is alive today." So like many people in the inner city, young people, he's lost lots of his friends, most of his friends, he would say, to violence. He saw his cousin or heard about his cousin being shot in his bed, and as a result, David says, "I don't sleep at night. I stay up all night and go to sleep in the day when there are folks around." He then says, "I have nightmares. I wake up crying, feeling lonely, wanting revenge." And then he held his brother as his brother died and talked about how he was crying and panicking. And then talks about how he thinks about how to contort his body so that a bullet, if it hit him, would not hit his vital organs. Well, how do we think about this? He's experienced lots of trauma, both chronic over his lifetime, as we heard before, and then recent acute trauma. Like many people with post-traumatic stress disorder, he's hyper-aroused, so he can't sleep. He has depression. He has re-experiencing, has had trauma on top of his original trauma, and then has more hyper-arousal that leads him into this kind of reenactment of his injury. This is a young person with full-blown PTSD, and this is not unusual, unfortunately. David is not alone. Although when folks like this enter the healthcare system, they're often treated like perpetrators of violence. The default, often because of our own held biases, is to blame this young person for his injuries. And so what do we know? We know that even among primary care populations, if you screen, in Boston, one study found 23% of primary care patients have PTSD, but only 11% of them have it noted in their charts. In studies of victims of violence conducted as a part of Healing Hurt People by my colleague and partner, Dr. Ted Corbin, 75% of the young people who had suffered either a penetrating injury or an assault had PTSD. We also then understand that violence is a recurrent problem. So if a person has been injured with a penetrating injury, their 5-year recurrence rate is 44%, and at 5 years, the mortality is 20%. So how do we think about this? How do we understand PTSD and how it plays out in the lives of these young people? Well, a young person like David who lives in an environment where he's subject to discrimination and racism, where he doesn't believe that the police will protect him, where he's seen a lot of violence, is often really haunted by hyperarousal, flashbacks, trauma, anxiety. In his environment, without access to health care that would diagnose and help him, he turns to what's in his environment. Marijuana or other drugs are a way of treating his own anxiety. But you know, if you smoke marijuana, you're not getting a job at Home Depot because they screen. And so he's cut off from legitimate employment simply by trying to treat his own distress. As mentioned earlier, these young people are often subject to victimization by the police, and they do not believe, David does not believe, that the police will protect him. If you live in a dangerous environment and you've been the victim of gun violence, and you do not believe that the police will protect you, what do? Well, you find a way to protect yourself. And these young people tell you guns are ubiquitous, easy to get. You don't have to pay much for them. And of course, given the human rights nightmare that's represented by mass incarceration in our country, it's likely that either of these pathways could end you up in jail, where you will hear more and more about, you'll be traumatized more in this setting and also have a greater sense of your own vulnerability. And then, of course, the likelihood that at either of these pathways could lead to death. So what can we do? And particularly thinking about the healthcare system. Let me give you one example of a trauma-informed approach or an intervention. There are a number of programs, more than 20 across the country, that are hospital-based interventions for victims of violence that are attempting to interrupt the cycle of violence by using case management, assessment, and screening for post-traumatic stress and other problems. Intensive intervention, many of them, again, using trauma principles. We have evidence from a number of places that these programs can decrease involvement with the criminal justice system, increase engagement with useful services, decrease re-injury. And so we have some models of ways in which healthcare could intervene. But this is really about how do we take some of the science that we know and how do we actually put it on the ground to actually help people. So if there are take-home messages I would offer for you, the first is, trauma feeds the cycle of violence. And we will not successfully interrupt the cycle of violence until we understand this early trauma and violence. And as was mentioned earlier, we also know that trauma feeds the likelihood of engagement with substance abuse and other drugs. We need, secondly, an implementation science that helps us understand how to take potential trauma or potential evidence-supported interventions and actually put them on the ground, so that we can actually see in the real world how they work. Many of these programs could yield benefits, but we just don't know because we're not out there and we're not studying in the right way. We also need to think about how we study different outcomes from recurrent violence or death, but look at mental health outcomes that relate to these young people. And finally, this goes beyond violence because, as was mentioned earlier, trauma increases the risk of chronic disease. Black men have the lowest life expectancy at birth. Is it possible that early childhood adversity, trauma, and stress are contributing to that through chronic disease and other problems? So if we are attentive to issues of trauma, we will not only intervene to help decrease violence, we will help to improve the health of populations and decrease health disparities. And I'll stop there.
David Kennedy was at the center of what's called the Boston Miracle, and maybe, David, you'll talk about that some. David is a professor at the John Jay College of Criminal Justice in New York.